So I think, cervical degenerative disorders are obviously something that we're all very familiar with. If we look at a common case of a young person who has a normal-looking neck in terms of arthritis, but presents with symptoms of upper extremity radiculopathy, no facet disease, but a large disc herniation at C4-5, I think this would be a very common patient that we would all see in our practices with this large disc herniation sitting on the right side causing weakness. And I think that we would all agree that in a scenario like this is a good surgical candidate. In the United States, cervical degenerative disorders are an increasingly common problem. And in the United States, we talk a lot about the value of certain treatments, and oftentimes value of different treatments is confused as the cheapest treatment. So the cheapest or least expensive treatment would be to tell the person never do surgery, but obviously that's not a long-term solution for a patient who has weakness coming from a cervical disc herniation. And I think certainly a reasonable option for this patient is a integrated zero-profile device. I think nobody can argue that a cervical interbody with plate would be a good option. I think also we should include a tubular posterior foraminotomy as an option, and obviously cervical disc replacement. And hopefully I'll talk to you guys a little bit about how I decide how to choose and which patients get what operation. It's a particular interest of mine, the cervical spine. We've published a lot of papers looking at the cost effectiveness as well as the clinical effectiveness of a lot of these different treatment options, and specifically looking at what is the value that we bring. So when we are deciding for a patient who has this issue, are all of the surgeries really the same, or are there slight differences in the options that we can provide to a particular patient where we really want to tailor a very personal option for what that patient needs, and perhaps that allows for the ultimately for the best outcome. If we're specifically looking at cost effectiveness, what is the value as far as cost goes, we've published some literature that suggests that perhaps disc replacement could be more cost effective than ACDF at one level. And this goes out to 5 years. And we've also looked at it in 2 levels, where we show that cervical disc arthroplasty in a patient with 2-level disease is also quite cost effective as compared to ACDF. Of course, ACDF is the gold standard. I think everybody in this room, I'm sure, performs many ACDFs as part of their practice, but it doesn't mean it's a perfect operation. Whether it's done through different options of different types of implants, there are complications that can occur due to ACDF. Now, some of these complications are approach-related, and so whether you're doing an ACDF, a cage plate, a disc arthroplasty, it's not going to matter. But some of these complications are specifically related to the operation that we choose, and specifically, if we think about adjacent level ossification disease as was presented and adjacent level disc disease, perhaps fusion versus arthroplasty, there could be some differences. Now, there has been an evolution in ACDF. I think in the beginnings of ACDF, back in the 50s when it was described, it was done with autograft and nothing else. And then we shifted to allograft. And then from allograft, we shifted to other types of biomaterials. We used plates. We didn't use plates. Now we have integrated plates. So what's the right answer? When we think about disc replacement, we have to think about what exactly are we doing. A disc replacement allows us to do a direct decompression, just like an ACDF, but it's motion sparing. And the advantage of having something that's motion sparing is obviously, as we just heard a very nice lecture about adjacent level disease, we think that there's a theoretical protection by allowing range of motion on that adjacent segment. And because a disc replacement is a zero-profile device, we think that there's also a protection as far as dysphagia goes, which is not an uncommon complaint in our patients after anterior cervical surgery. And also, we eliminate the likelihood of adjacent level ossification disease, which is a variation of adjacent segment disease and is specifically related to the use of an anterior cervical plate. A disc replacement is technically a little bit more challenging, and we'll go over some of the tips to this. In the United States, to get Payment for disc replacement can sometimes be challenging, and certainly in multi-level disease, it may not be an option. A posterior cervical foraminotomy is another option for a patient with cervical disc disease because it allows direct decompression. It's minimally invasive, and I'll talk a little bit more about this in my lecture on minimally invasive cervical surgery, and it is motion preserving just like a cervical disc replacement is. But oftentimes, doing a minimally invasive cervical foraminotomy to preserve the muscles can be technically demanding, and if there are multiple levels involved, or if there's any kyphosis at the segment that we are operating on, a cervical foraminotomy is not as predictable. So we have to consider, what is the pathology that we're treating? Are we treating central stenosis? Are we treating OPLL? Is the stenosis foraminal, soft disc, hard disc? All of these things are going to go into our thought process when we're considering what type of operation a patient should have. So for example, we have a patient here who has 2-level cervical disc degeneration at C5-6 and C6-7, but also has a spondylolisthesis at C4-5. And if we look more closely at this patient's MRI, there's multi-level cervical disc disease, but this patient's only complaint is right upper extremity radiculopathy, and that radiculopathy only goes into the patient's shoulder and upper arm and doesn't pass the elbow. This is the patient's axial MRIs. We can see at C4-5 there's a foraminal disc herniation, and while there is stenosis at C5-6 and C6-7, it's pretty bilateral. And here, while we can make a case to do a multi-level operation, I think doing a single-level operation in this patient can be effective, and you can certainly use a plate option, and we can see that we can get a good decompression post-operatively. This is 1 year post-surgery where the patient had an MRI done, and they had good decompression, and there is some amount, of adjacent segment degeneration that has occurred where there's a little bit more stenosis at C5-6 and C6-7 than there was. So perhaps there is definitely some truth to the adjacent segment disease. So thinking about this, we said, how can we prevent some of the things? Maybe we're exposing a little bit more, and so can we do a more focal operation? And that's where the advent of the zero-profile fusion came with a cage and integrated fixation. And this is a gentleman who has a kyphotic neck and presents with cervical radiculopathy. We could see even on the CT scan he has cervical kyphosis, but his facet joints are reasonably clean. He has an MRI that shows a left-sided C6-7 disc herniation, and his only symptoms, again, are just in his triceps. So we did a zero-profile fusion on this patient at C6-7, and specifically we did this so that we could try to preserve C5-6, which had some degeneration to begin with. This is a good operation also at multiple levels, where we could do 2 levels. When we're doing a zero-profile implant, it's very important to try to get excellent coverage of your end plate. So oftentimes when allograft is used, we use a smaller allograft that could only be 14 millimeters wide. Some of the advantages of the zero-profile implants are that they come in wide footprints, and that can allow for excellent coverage and hopefully less subsidence. Also, as we get to the upper spinal levels, this is a patient who had a previous fusion done, and as we get to the upper spinal levels, you can see a very large disc herniation up at C2-3, also stenosis at C3-4, and you can see significant cord compression. This is a challenging area at C2-3 to place a plate on, and certainly can be a source of dysphagia if we place a plate there. And this is a nice option for a zero-profile implant to be able to get up high in the cervical spine and not have to place a plate that can otherwise result in dysphagia. What about cervical disc replacement? So this is a young patient who's got a focal disc herniation with an extruded disc fragment, and I think this is an excellent candidate for a cervical disc replacement. There's no facet arthritis. We can get excellent sort of restoration after decompression and perform a cervical arthroplasty that can be preserving of motion, and I think especially in the younger patient, the cervical disc arthroplasty is a good option. I often get asked, how do you do a cervical arthroplasty in a patient with a really big neck? So when we're doing a cervical arthroplasty, you have to be able to see end plates. You don't have the option of being able to cheat without seeing. So you have to be very cognizant with fluoroscopy, and we can see this is this patient. If we cone down the beam, we can get a good look at the level, and so we can do a cervical disc replacement. Oftentimes surgeons will come to me and say, you know, I don't like cervical disc replacement at C6-7 because if I can't see, I'm not going to know that until I get into the operating room. But I think that you have to be comfortable with doing things with your C-arm that can make this a good option. Here's a patient with, again, with a large disc herniation, a young patient, focal disc herniation, where we used a different type of arthroplasty implant, of which there are many, of course, but I think, again, it's a nice option. I think as we go to multiple levels, if we can do non-fusion surgeries, this can be very effective for the patient and also beneficial. So this is a patient with a 2-level problem, and I think, you know, obviously we can see spinal cord compression at 2 levels. Although there is cervical kyphosis on an X-ray, if we look at the CT scan, the facet joints are clean, and we do see good lordosis. And if we see a good restoration of lordosis, then at that point, I think a cervical disc replacement is a good option. If you see persistent kyphosis, then a cervical disc replacement may not be such a good option. When we're doing a cervical disc replacement, technically, you know, where you place your distraction pins, how you get your distraction, and the type of coverage you get is very important. So in a cervical disc replacement, you want to get all the way posteriorly with your coverage of the end plates. So you can see the 2-level disc replacement, and you want to get really all the way to the back. If you leave your disc arthroplasty too small, you are not going to have a good outcome, and you are going to risk fracturing the end plate and have subsidence. So you want to put an arthroplasty that's as wide and deep as possible for this type of problem. Arthroplasty, unfortunately, you know, wouldn't work for a patient like this. This is a patient with a 3-level issue, maybe more than a 3-level issue, but we treated his myelomalacia and spinal cord compression, and we decided that we were going to do the 3 levels of the most severe stenosis, and we did a 3-level standalone. And I would argue that in this patient, being able to do 3 standalones, which can allow for a smaller exposure, less retraction of the esophagus, can be extremely valuable. So when it comes to my decision making, this is what I think about. If I have 1 or 2-level disc disease without any facet arthropathy, then I like to do a cervical disc replacement. If I have a patient who has a cervical degenerative disc issue with stenosis and has facet arthritis, then I think a standalone ACDF at 1 level, 2 levels, 3 levels, however many levels, as long as you put in a big cage, you are going to get a fusion. If it's a single-level lateralized disc herniation, there's no kyphosis and minimal neck pain, then I think a foraminotomy is an excellent option. Thank you.